this case, the case of a young lady. She is 58, and she came to us because of a nodule in the right portion of her neck, possibly through the thyroid. And this lady is Thyroid, and she performed ultrasound first. And we can have a look of the procedure. Actually, the nodule is a thyroid nodule, and it involves the two upper thirds of the right lobe, and it has a fluid component, but the solid component is highly prevalent. And coming to its vascularization, well, vascularization is mainly peripheral, as we'll see here. There is still some vessels within the nodule. Well, the patient complained of the nodule because it's rather large. Actually, its longest diameter is 38 millimeters, and when we estimated its volume turned out to be 9.2 ml. As I said, the patient complained of this nodule because of its size and because of aesthetic problems, because she was unhappy of how it looks and how she looked. Actually, this was the reason why she came to us and thought to solve her problem and to destroy the nodule. First of all, we scheduled the patient for aspiration biopsy, and we performed 2 aspiration biopsies. Both of them showed that the nodule is absolutely benign. It means that we have a benign nodule, 9.2 ml in volume. It's a symptomatic nodule, and therefore the patient could be referred for thermoablation. Actually, we suggested performing radiofrequency ablation of the thyroid, of this nodule. We selected an 18 gauge needle with a 7 millimeters exposed tip, and our idea is to enter through the isthmus and then to follow the needle till the most deepest and lowest and medial portions of the nodule. Then we will use the so-called moving shot technique, and we will try to destroy the nodule first in these portions, I mean lower and deepest portions, then in more superficial areas of the nodule, and then moving the needle till the more cranial aspects of the nodule. Local anesthesia is applied here on the midline. And the generator is set up here. Actually, we prefer the manual mode in order to set manually both the time and the power we apply. Now we are introducing the needle in the lower portion of the nodule, actually in the lower and more medial portions of the nodule. Here is the tip of the needle reaching the site where we desired to place it, and now we can start with the procedure in a while. Yes, here the hyperechogenicity comes, and you can realize that we applied 30 watts. The impedance is 127, and now the impedance starts rising a little bit. Yes, now it goes, and the hyperechogenicity enlarges at the same time. Now we can withdraw the needle, and we can ablate the lower and medial parts of the nodule. Now we place the needle still in the lower portions of the nodule, but in the more lateral aspects. And here again, the hyperechogenicity enlarges, and at the same time, no question, impedance starts rising, and we can withdraw the needle. Here again, the impedance rising. Now we are going to treat the central portions of the nodule, and here again the change in hyperechogenicity and the impedance changing as well at the same time. Now the needle is placed into the more lateral and superficial portions of the nodule in its mid part. And now we are going to place the needle into the more cranial aspects of the nodule. Here is a fluid component, a small fluid component of the nodule. We can now withdraw the needle, and we are close to the end of the procedure, and we are close to remove the needle. And the procedure now is over. The procedure worked well, definitely. And then of course we can check the vascularization of the nodule, and here the power Doppler showing that the vascularization is only peripheral. The patient came back for the usual follow-up following the procedure, and her thyroid function was checked 1 month and 3 months following the procedure and remained unchanged. And she performed ultrasound and color Doppler of the thyroid as well. This is the image before the procedure, and here is the image 1 month after. The nodule underwent a clear decrease in terms of volume, and its echogenicity changed as well. Now the nodule is hypoechogenic, with the exception of this triangle, the so-called danger triangle, which is still hyperechogenic because it was not treated. It was not intentionally treated to preserve nervous structures in that area. And if we consider vascularization of the nodule, here is the vascularization before the procedure, here is the vascularization 1 month after. Actually, vascularization within the nodule entirely disappeared, with the exception of the danger triangle. And now we can consider what happened 3 months after the procedure. Again, the nodule is still hypoechogenic, and we can estimate the decrease of the volume. Actually, the volume of the nodule was 9.2 ml before the procedure, and it's 3.9 ml 3 months after the procedure. That is, we had a decrease by 58% of the nodular volume, and actually we expect that such decrease can be even larger at the next follow-up 6 months after the procedure.